Hello. Today I'd like to talk about prescribing during breastfeeding, and this talk today is specifically aimed at midwives. My name is Wendy Jones and I'm a pharmacist, but I'd like to explain a little bit more about my background and where I came from. I was born over a Boots pharmacy because my father was the manager of the shop. There was never any other career that I was going to have. But later on, I had my 3 children and became more and more interested in breastfeeding and the profound effect that it had on me. I have a chronic condition called Crohn's disease, and I was always healthiest when I was pregnant or breastfeeding. I trained to become a breastfeeding counsellor back in 1987, and I became more and more interested in drugs in breast milk, being able to put together the two sides of my knowledge, understanding about breastfeeding and understanding about medication. But I reached a point where I didn't feel that I knew enough. So I went away and I conducted a PhD study on what community pharmacists know about advising mothers who are breastfeeding and needing medication. And my knowledge continued to grow. At that time, I was a community pharmacist, a manager of my own pharmacy, and we had a really good client base. And it was my passion to talk to mothers about the health of their children. I began writing books, and my first book, Breastfeeding and Medication, was published in 2013, and the other books followed. In 2019, I had the very great honour of being awarded an MBE presented to me by the Queen at Windsor Castle for services to mothers and babies, something I never ever believed was going to happen to someone like me who just followed their passion. But I'd like to share some of the information and knowledge that I've gained over the years with you today. We know that breastfeeding affects women's use of medication. I found this in my own PhD research, which was published back in 2000, but it's also been echoed in other studies since. So if a woman is breastfeeding, she will do her utmost not to take a drug in order to keep her breast milk as pure, for lack of any other word, as possible. But we actually give more than 56% of mothers some kind of medication in the first 5 days after delivery. And unsurprisingly, most of these are analgesics and antibiotics, the necessary part of midwifery care. Back in 2016, Rollins posted this quite mind-blowing article that showed that at 12 months we had the lowest breastfeeding rate in the world. But unfortunately, some of this is actually lack of data because nobody asks the questions of mums with older babies. And I actually see many mums with much older babies breastfeeding and continuing to do so very happily to term. But they're the ones who actually have more problems when they are being prescribed medication, because there seems to be a lack of belief that breastfeeding breast milk has advantages at that stage. It actually does, and there is some research that shows that the nutritional value doesn't change at all with time. The first quote here about breastfeeding being on par with immunisation was one of the first studies that I looked at back in 1994. And it literally blew my head about actually how breastfeeding is a public health imperative. And that was echoed again in the Lancet papers in 2016, that actually it would deserve a Nobel Prize for Medicine and Economics because it has so much to offer. It's not just about a choice we make on how we feed our babies. It's about our, as women and babies' future health. So why do I need to keep producing these books and presentations? And it's sadly because most of us as professionals don't get undergraduate training on breastfeeding, let alone drugs in breast milk. And at the moment, the BNF doesn't provide quantitative information on the safety of drugs in breast milk. So it doesn't differentiate between whether the baby is preterm, term, or an older nursling. And we're all very cautious about harming babies because there are two parts of a relationship when we give a drug to a breastfeeding mother, and we can't ignore the needs of the baby as well. And it's very right that if we don't know what is going to happen, then we shouldn't be prescribing. Most drugs pass into breast milk by simple diffusion, so going from the highest concentration in the mother's bloodstream to a lower concentration in milk. But the same is true as the mum's level comes down in her bloodstream, the drug is pulled back out of her milk, and then she deactivates it in normal ways. So drugs on the whole are not stuck in breast milk. In the first few days after birth, there are wide open gaps between the alveolar cells to enable immunoglobulins to pass freely through to the baby. But actually, this is the time when we give most drugs, and the drugs also are able to pass straight through these gaps. But this is probably a time when we are least concerned because custom and practice, as midwives and paediatric doctors and pharmacists, we know and are comfortable with the drugs that we're using. It's only later that people seem to become more concerned. After the first few days, roughly about the time that full milk comes in, the alveolar cells close up and the drugs then have to cross the cellular membranes to get through into breast milk. But I've been told things like, I've been advised I can feed for the first 6 weeks, then it would be better to artificially feed, A, as it has no benefit, and B, the risk of the drug is higher. Well, actually, how does that make sense? Possibly in the fact that the volume of colostrum is very small, but by 6 weeks we have a full milk supply. Breast milk is still a major benefit, and actually by 6 weeks the baby's own kidney and hepatic function is at full force, and it can detoxify any of the drugs that it receives through breast milk. We need to consider things like half-life. The half-life is the time that it takes for half of the drug to leave the system. And we assume that after 5 half-lives, enough has gone that effectively there is none left. This is fine until the half-life of drug is more than 24 hours. So after 24 hours, we may have, as an example, 50% left. So then we're giving another 100% and we have 150%. After 2 half-lives, we've still got 25% of the first dose, 50% of the second dose, and 100% of the third dose. And the amount getting through in breast milk is actually starting to accumulate. So this affects things like pethidine and particularly fluconazole. And the baby's liver and kidneys are not able to fully metabolize the drugs until they're 6 weeks old. So we want to avoid any drug with a long half-life in those first 6 weeks. If a drug has low oral bioavailability, it doesn't matter how much we give after those first few days, because if the mother can't absorb it from the gut, neither can the baby. So things like gentamicin, teicoplanin, insulin can't be absorbed by the baby any more than they can by the mother. So these are amongst the safest drugs, and it includes the anti-TNF biological drugs, which many people are very concerned about. In the BNF, you may find quotes like, "The amount in breast milk is unlikely to be harmful, but manufacturers advise avoid." And most professionals, particularly pharmacists, tend to focus on the second part of this sentence, thinking that the manufacturers must have some kind of data on file to show that the drug is harmful. In fact, they don't. They're not required to undertake tests when they first license a drug, nor are they required to report on any studies that happen subsequently. So that statement stays there. But if we have that statement, how do we make an informed choice? We can look at the amount is unlikely to be harmful, but that feels a bit wishy-washy. We need to look in specialist sources that are not just the standard drugs that we have in our pockets, at the nurse's station, wherever we keep the BNF. And we need to think, is it going to be different if the baby is only feeding once or twice a day compared to a newborn? I mentioned the anti-TNF drugs, the biologicals. I have a Facebook page for breastfeeding mums with inflammatory bowel disease because of my own interest. And mothers are repeatedly told that they can't have biological drugs and continue to breastfeed. But they know that they're having them by injection or infusion because they can't be absorbed from the gut. They also know that breastfeeding in itself is protecting their babies from developing the condition. And as women, we will all do anything to protect our babies. As we've already discussed, if a drug isn't bioavailable in the mother, it's not bioavailable in the baby. So these quite wonder drugs can be given. The only thing that we need to avoid is the rotavirus vaccine. If the mother has had it in the third trimester, then it's contraindicated in the baby anyway. If the mother has stopped having them earlier in her pregnancy, the baby could receive it, but the mother might pick up the live virus particles from feces for the following 2 weeks after vaccination, and she's the one at risk. So rotavirus is very uncommon in exclusively breastfed babies, so we could just leave this out of the vaccination schedule, or we can advise mums to wear gloves whenever they change dirty nappies for 2 weeks after the vaccination. It takes a drug 5 half-lives to leave the system. It also takes 5 half-lives to reach a steady state. And often mothers are told that they should time their feeds with a drug in order to have a peak level, a trough level, and avoid the peaks. But actually, once you've got through these 5 half-lives, there's a slight variation, but mostly there is a steady state and it doesn't matter. So I've often been told that mums have to discard for a period of time after they've taken their medication. And it's certainly true of drugs like sertraline. When they're doing everything to avoid harming their babies because their anxiety is so high to protect their child. So they'll try to avoid feeding for 4 to 6 hours. So they'll take their drug in the evening time when the baby hopefully has a longer period of sleep. But we know this doesn't always work. Babies wake up for all sorts of reasons. Maybe they're teething, maybe they're hot, maybe they're ill, maybe they just want to cuddle. And of course, maybe they're hungry. But what does she do then? Does she just walk the floor until the 4 to 6 hours is gone? When actually there's no need for any of this. It's there for the full 24 hours. Otherwise, if you think about it, her anxiety or her depression is going to start coming back before her next dose, which obviously makes no sense at all. The relative infant dose is a standard measure that's been developed across the breastfeeding medication world as the gold standard. Now, you won't find this in standard books. It's widely used by Hale in medications and mother's milk, and I've picked up and used it in my book, though it was actually first introduced back in 1996. The relative infant dose, if it's less than 10%, in general, the drug is compatible with breastfeeding. But we can't just take this in isolation. We need to look at the whole of the pharmacokinetics. I was lucky enough to be involved in developing the anaesthesia and sedation guidelines. I first raised the issue because I was frequently being told that women couldn't breastfeed for 24 hours after a general anaesthetic, but I struggled to find any evidence for this, and in fact, a lot of evidence for the contrary. And women were developing mastitis, telling me that their babies were refusing a bottle. They were trying desperately to get home sooner than might have been beneficial for their own symptoms. And it did take us quite a while to write the guidelines, but this small little, I want to call it an app, it's not an app, information card was meant to be laminated and held in all surgical areas so that it had quick and easy information. We have to remember about the risk and the benefit. And most of the drugs that are used in anaesthesia are gone very rapidly after the woman is awake and alert. And there is no reason that she can't continue to breastfeed as soon as she can safely handle her baby. I keep this quote in because I think there is such a story behind this woman's words. Trying to get to a hospital for 8 o'clock in the morning with a 5-month-old is not easy. It's never easy to transport children when we want them to, is it? She was back in the car 20 minutes later because she said she was breastfeeding, and they said, right, you can't have the procedure. She'd gone back when the baby was 1 year old, just had the MRI. She was still breastfeeding, but nobody asked her. Because actually the pharmacokinetics of the contrast that we use in an MRI make it a very minimal risk. So the oral bioavailability of gadolinium is very, very small, and it's completely gone from the system after 8.5 hours anyway. So the guidelines in many situations said don't feed for 24 hours, which just didn't make sense. But if we actually stop and think, what was the cost to the NHS of this cancellation? This mother had been referred because she needed an MRI for an illness that she had, and she actually waited 7 months before she had the procedure. What a waste for everybody. Midazolam is covered in the anaesthesia and sedation guidelines, and it's widely used for colonoscopies, for dental procedures, for colposcopies. But women are often told again they mustn't breastfeed for at least 24 hours, but very frequently 24 hours. When I looked at it, the original study came from one that was used in comparison with nitrazepam as a sedative where the mothers had newborns. And the study showed that after 4 hours, the level was undetectable. But these were newborns where the gaps between the cells would have been wide open. So more would have got through than normal. And in fact, the amount being absorbed by the baby is minimal. And there's no reason that a mother who has had sedation can't breastfeed again as soon as she's awake and alert. It's probably advisable that she has somebody else to watch over them both that evening because she may be slightly drowsy. I remember when my daughter had a colonoscopy when she had a 4-month-old baby, and she said to the consultant, can I come back again tomorrow and have this done again? And it's very confusing. Most people don't say that. And she said, that's the best sleep I've had in months. I'm sure many of you have had a lot of confusion around the COVID-19 vaccines, because it was, when it first came out in December 20, it was licensed, but only to be used when breastfeeding had ceased. And many professionals felt that they had to stop breastfeeding in order to protect themselves and their families. But again, like many other things, vaccines are large molecules and can't pass into breast milk. And we had some statements, but it took until January 2021 before the MHRA made a TV statement that breastfeeding mothers could have the vaccine and continue to breastfeed. But the paperwork took time to amend, and professionals got confused, women got turned away. And I think often this was at the basis of women avoiding having it. There's a lot of misunderstanding about the risks of interpreting breastfeeding. This mum told me that she had iritis and had been given steroid eye drops and was told she had to pump and dump for a week. She contacted me after the first night and her baby was screaming in pain with trapped wind. Actually, for her, the problems of trying not to breastfeed were enormous, and there was no reason at all why she couldn't continue to breastfeed, because if you use punctate pressure over the teardrop, the amount of steroid being absorbed is minimal anyway. I did a small piece of research on my website and Facebook page, Breastfeeding and Medication, asking mothers what do they want professionals to know about nipple pain. I've put the link here because there is so much information in there. People needing everyone to understand that formula isn't the only solution. What they wanted was somebody to sit and listen and help, and just telling them to give a bottle wasn't the answer. And for health professionals who didn't have an expertise in breastfeeding, it was okay to say, I don't know, and to send them on to somebody else who could help them. And the answer that breast pain is not always thrush. I did a similar piece of work about perinatal women with mental health problems, particularly around anxiety and depression. And they reported so frequently that actually stopping breastfeeding made them feel worse because they lost the value of oxytocin, and how much they value people being well informed and not having to have a battle. Sadly, one of the things that keeps being said is women don't tell professionals that they're breastfeeding because they won't get into a discussion about how they've chosen to feed their baby. Again, the link with all the data is there. I've been very lucky to be involved in the Safer Medicines in Pregnancy and Breastfeeding Consortium set up by the MHRA, with lots of the leading organisations, including third sector, as well as the NHS and regulators, trying to look at the data that we need to enable mothers and professionals to reach a joint decision. And there are some changes being made to the BNF, which help a lot more than that original statement that said manufacturer as advisors avoid. It's a very powerful organisation, and I hope to see much more of it. Any drug that's licensed for children is going to be compatible with breastfeeding. So things like loratadine and mebendazole, the amount passing through in breast milk is minimal. Particularly if you look at loratadine, the licensed dose at 2 years is half of an adult dose because it has a wide therapeutic index. We need to remember that medicine plays an important role in women's decisions about continuing to breastfeed, and they often feel very strongly about tainting their milk. And we need to involve them in the discussions and provide them with information in a way that they can understand to help them make the choices that are right for them. So over the past 25 years now, I've been involved with the Breastfeeding Network, running the Drugs in Breast Milk helpline, answering questions on social media, predominantly these days about drugs in breast milk. I left BFN in October last year because I'd been taking somewhere around 10,000 questions a year, and I felt it was about time that I handed over the baton. There are now 11 wonderful pharmacists providing this service in a rota, and some more about to be trained. So we will always endeavour to ask the mother what she wants to do, provide her with the information and interpret it so that she can access it, or for professionals as well, to let everybody make the right choices. Antibiotics can cause temporary lactose intolerance in the baby, often seen as very loose nappies, but it's an inconvenience rather than a harmful reaction, and it does recover without any treatment. They don't need to take probiotics or anything else. Metronidazole is said to alter the taste of the milk, but we don't seem to be able to trace back where that first came from, and I wonder whether it came from flagyl, which used to have a bright yellow dye in it, colouring the milk. Toddlers certainly don't seem to have any problem, and apparently if you eat a lot of garlic in the diet, it covers up any taste anyway. Coamoxiclav and erythromycin seem to cause more stomach pains in babies. We don't know why, it's just something we've noticed. But remember, mum's passing on antibodies to the infection she's had, and she can't transfer the infection through her breast milk. And that's been very important throughout COVID. Hypertension, I'm sure many midwives are familiar with treating, and we will often give labetalol in the final stages of pregnancy for a mum with preeclampsia. Once the baby's born, be alert for white nipples after feeds, because labetalol can affect the blood supply at extremities and give white tips. If we're using an ACE inhibitor, use enalapril rather than the more frequently used ramipril or perindopril, because it's the drug with most evidence. Amlodipine, you see, has a very low relative infant dose, as has nifedipine, and we also use nifedipine with women who have a history of Raynaud's phenomenon, where you see a change in a nipple colour from white to purple to red to white again, rapid colour changes. And we want to avoid diuretics because they will reduce milk supply. Pain relief. Paracetamol, the NSAIDs are all compatible with breastfeeding. If we're using opioids, we need to use them in the lowest possible dose for the shortest possible time. And ideally, we will use oral morphine or dihydrocodeine. We want to avoid codeine because some people have a metabolism that concentrates the levels in milk. And there was one sad case in Canada where the baby died. There are other reported cases, but very few. But if a mother is used to taking the drug, it probably isn't a condition that she has. Those of us who have this metabolism will do anything to avoid opioids. But if you give an opioid, don't forget laxatives. The fourth stage of labour is just as bad as the others. Sitting with constipation, if you've got stitches or a C-section, is no fun. So we can use osmotic, bulk or stool softeners, and we can use occasional doses of Senna and Bezicodal as stimulants as well, with no interruption to breastfeeding. We need to remember that overall we want to do no harm. But breast milk doesn't turn off like a tap, and suddenly interrupting breastfeeding can cause a host of other problems. Mastitis, babies refusing to feed, milk supply dropping, all of which were unnecessary in the first place if we'd used expert sources of information. Variety of expert sources. Obviously, I'm going to say use my books. LactMed is freely available online and is free. I have the app on my phone so that I can have the information all the time. UK Dialysis is a subsidiary of UKMI and produces some fantastic fact sheets for the NHS. You can phone them up and discuss any patient you want as well. Medications and Mother's Milk is probably the Bible of all drugs. It has any drug and every drug I think you could possibly think of. There are lots of fact sheets on the BFN website and my website, which have been developed over the years to save you time. So I've done the research so that you don't need to. I think the final message I want to give is we need to change the conversation. We need to practice shared decision making and promote and support breastfeeding, and find a drug that a woman can breastfeed on. So rather than saying, I need to prescribe this drug, can the women breastfeed? Let's start with, this mum is breastfeeding, what's the best drug that she can take? All of us need to have training on breastfeeding, the safety of drugs in breast milk, but we need to be very sensitive to the needs of mothers around their infant feeding. Some may want to stop because they're not enjoying it or it's not working for them, and that's their right. Others are desperate to feed, and that's their right. And we support anybody and everybody. If you have any questions, I'm always very pleased to answer anything that I can. So thank you for listening, and I hope this has been useful.